Okay, I guess I.
Recording has started.
Okay, so it's a real privilege to be here and truly to talk about community engaged research, which to me is the ultimate in translation research because we are working with communities. And forgive me because I'm standing here with my hand on the button. So we'll talk about some of the principles of community engaged research with a focus on community based participatory research. And by the way, you may have a copy of these slides.
We'll get them and put them on the website.
Okay. And so we'll talk about community engagement also in the context of research frameworks because communities traditionally, at least the communities that I work with, when we talk about research, they sit back and say, okay, what are you going to do to us now? And so we will talk about it in the context of research frameworks and partnerships and level of the partnerships. And then we'll review some of the basics of data collection and just a couple of guidelines for evaluation. So the real world is trying to work across the research spectrum, from bench to bedside to countryside is really what we're talking about with translation. And so what is translation? And it's the process of turning observations in the laboratory, in the clinic, and community into interventions that improve the health of individuals and the public. And translational science, that is the science of how do we do this, is relatively new. And we really are developing that process because most of the time as a researcher we just simply say, oh, this is what we do and these are our outcomes. But how do we best translate using good science? And that has been underdeveloped from my perception. What about yours, Heather? Yeah, so I think we can say that it's truly a relatively new science. And Henry David Thoreau is one of my favorites. And he says if you build castles in the air, your work need not be lost. That is where it should be. Now, put foundations under them. And in reality, I think when we talk about community engaged research and community based participatory research, that's what we're trying to do. We're trying to build that foundation for translation. And this is kind of an old model of translational science. And we just were at a workshop where Chris Austin, who's the head of NCATS, which is the Clinical and Translational Research Awards, said, oh, we took this model into the community and nobody understood it. And if you look at it, it's relatively complex. And so what they've come up with is a circular model that talks about the clinic, it talks about the patients, etc. And in the middle is the research process. So we'll soon have that model to replace this one. And so when we're looking at translation, you and I both know that there's lots of roadblocks. There's folks who are willing to participate and those who are not. Then you'll learn as a community member about some of the regulatory burdens that we face as researchers. The infrastructure is fragmented because traditionally the health infrastructure is set up to deliver care rather than truly engage in research. And so the academic institutions have taken that role. And therefore, there are, when we look at translation research, there's a lack of qualified investigators. And those are some of the translational roadblocks. And of course, when we look at community engaged research, there has traditionally been some roadblocks in lack of funding, but that's changing, and I think PCORI is a perfect example. The patients, let's see, PCORI is what? Patient-centered Outcomes Research Institute, right? All of a sudden, it was like, okay, what is PCORI? So PCORI is working truly on that translation research. And we know that we all really work passionately but frequently separately. And so the role of community-based participatory research, the role of PCORI, is really bringing together that academic community partnership. And we also have probably heard many times that our research or academic institutions are ivory towers, and we don't understand what it's like to work in the real world. Anybody in here ever said that, community members? I see some smiles and some laughs. And so our role is really now working together to connect those silos, because we have lots of silos. And if we're going to translate research and come together and really improve health, we have to connect the silos. We have to work more efficiently and more effectively with the dollars that we have and the time that we have to really connect these silos. And so the Institute of Medicine has recommended that we ensure community engagement in all phases of research. And that was one of it was recommendation number 6 out of 7. So how do we do that? What about the bench researcher? We had a bench researcher who came to our community engagement classes that was really struggling. He had developed a test for AIDS that was less cost effective, and he was testing this, and he was struggling about, how do I involve all the community, how do I build this network of people to really test this? He said, I've been a lab rat all my life, and so now I need to go out and find ways to do this. How do I involve industry? How do I involve others in testing? What kind of communications do I need to do with the community that I'm involving? So he was struggling to involve community. So when we're thinking of as researchers, when we're thinking about community, we need to define community engagement. What communities are we working with? How do we consistently apply our definitions across the research project? Because communities can be many things. Anybody got definitions of community that you want to share? What do you think a community is? If I ask you to define your community, what would you say?
It's a group of people occupying a similar space or in a certain locale. Some commonality.
And so, yes, that geographic community is one. Then the commonality, all of us belong to multiple communities. We live in a geographic community. We work in a community. And so many of the folks that I work with say, oh, the hospital's not in the community. And for me, I view the hospital as an essential component of the community. But the hospital is a community within itself, with norms and values and practices that those outside the community don't understand. And so we want to define our communities, and then we want to ensure community stakeholder participation in priority setting, in decision making across all phases of research, as well as the leadership and governance. And we usually have board of directors and board of visitors. We have a board of visitors, and I'm like, what in the heck is a board of visitors at the Medical University of South Carolina? And in reality, I think that's a lot of the people who are donors, etc., maybe in preparation for our board, the big board that makes decisions. Then once we define our community, get our stakeholders involved, we want to define and clearly communicate goals and expectations, because people get really confused. If I ask you, what do you expect from participating in the ASA Awards? How would you define that? And we went around, we would find that we have different definitions, different goals, different expectations. So as researchers, we want to clearly define those goals and expectations. And that needs input both from the community members that are outside the academic institution as well as those in. And then how do we engage and explore opportunities for a more diverse community? So what is community engagement? And here you see the definition, and I'll just simply read it. Scientific inquiry conducted in communities and in partnership with researchers. And the process is such that the community members, persons affected by the condition, the disability, or the issue under study, or other key stakeholders have the opportunity to be full participants in each phase of research. And I will tell you that in the Progress in Community Health Partnerships, a journal that Hopkins publishes, if you say you're doing community-based participatory research and you don't engage the community members in the analysis and interpretation of the research, the manuscript will be returned. So there are those who believe that community needs to be involved with community-based participatory research in each of the phases of research. There is a book that you can download called Principles of Community Engagement, and it's free. This, I believe, is the second edition, and I know there's some discussion about a third edition. So what are some models or frameworks that are used? Here's one that was developed by a group of folks, and then DJ McCloskey, who was with NIH and a community and involved in community engaged research, modified this. We use this a lot with our community engaged scholars at Medical University. And by the way, that is the organization that's similar to the ACE Awards. So oftentimes community engagement may simply start with outreach or consulting with the community. Then it may move up to involving the community in both discussions and participation. And then we develop collaboration with the community, and then community-based participatory research, which is what you're talking about, is true shared leadership. It's easy to say shared leadership. But when it comes down to that grant writing process, if I ask you who did the major grant writing part of your application to ACE, you probably would say it's the academic person, right? Yeah, that's the case usually. However, the greater involvement of the community person who's involved, the more opportunities that the community has for not only engaging in grants for research, but engaging in grant development for ongoing sustainability and the creativity that you may bring to your organization. So don't sit back as community members and let your academic member do all the writing. Certainly your academic member may be the one that leads that team because of their experience if it's going to a peer-reviewed journal. But get involved. In one of our projects that started in 1999 and was funded continuously through 2012, we have a community member who does not have a high school education now writing grants and sustaining their coalition. Wow. And doing it in not just the local community foundation, but statewide grants, and now has engaged in regional HHS grants. So I say that to say this: never underestimate the power that one has based on their education, because there's formal and informal education. So just think about that as you start that grant writing process for future grants, and then for shared leadership as you move through. The more you can participate and learn, the greater opportunities for really sustaining and creating community programs. Here's another more simplified way where we say that community-based participatory research leads to shared leadership and can be community-led. And this we saw last year in your workshop with the speaker who came, and I particularly liked this, but it's kind of a clear ladder of participation for community engaged research, and put some names of community placed. Lots of things take place in communities, but then there's the community based and community engaged, community participatory. So spend a little bit of time thinking about that, thinking about where your research that you're doing now, where does it fit on this ladder? and lots of keywords that we could add to, I'm sure. But one is certainly the foundation, and that is building trust. Because if we don't learn to trust as we move forward, we oftentimes have problems with sustaining our work. And then being able to share is a foundation for building that trust. When we look at health and we think of the healthcare institution, and we think, oh, they establish or maintain the health in a community. But in reality, if you look at this, the healthcare really only makes about 10% of the difference, according to McGinnis, when they looked at health promotion. So major issues are behavioral problems. And then there's the genetic behavioral patterns. And there's the genetic predisposition that certainly is mostly not modified, even though we're learning how to modify some of that. The social circumstances, then comes health, and then the environmental exposure. And I'm not sure if this would be the same today. I think some of the environmental exposure may be expanded, particularly in some research that's being done. And another way to look at health and to think about all the contributors to our life course. And this one has environment playing a large role or surrounding each of the variables. But looking at the individual and population, we can think of the pathophysiology, the genetic or constitutional factors, the risk factors that we engage in, such as smoking, etc., our social relationships, our living conditions, and we know that people who live in certain neighborhoods and communities are more vulnerable than others. And our social and economic policies play a major role. Here's another one. This is Dr. Frieden, who's the CDC director, looks at how do we have an impact on health. And most of us in the healthcare institutions think counseling and education and clinical interventions. That's how we impact. But we're seeing more and more about the socio-ecological factors and really changing policy to help people make better decisions, etc. So what is the ideal community-based participatory research? And one is when you combine the academic rigor that really says these findings in this research project are real, with the faith that the findings will fit into the real world outcomes. And that's always, as Heather's shaking her head, that is always an ongoing challenge. And I'll give you a very concrete example of that. We just finished a project in Bamberg, South Carolina, one of the very underserved communities in rural South Carolina. And we were going to recruit people with diabetes who were admitted to the hospital with any diagnosis into a research project, and they were going to be randomly assigned to usual care, nurse telephone delivered care coordination plus usual care, or community health worker in-home care coordination plus the usual care. Well, initially, the community hospital said, oh, we got plenty of patients. Wasn't the case. We had statistics that said, oh, we admit this many patients. Well, what had happened is, from the time the statistics were collected until the time we did the research project, one of the hospitals closed. The hospital that we were working with purchased two of the community practices, and all the others went independent. When we went in and worked with the community, this is what they were willing to do. When we went to the hospital again, they said, well, we really just want to do this with the practices that we purchased. That was fine. We said, great. But guess what? The practices that they purchased, one closed. The other one lost 3 of their practice providers, and a new physician joined that practice. So at the end of 6 months, we had about 10 of the 60 people that were even eligible to be considered. So we are scratching our heads and saying, oops, what do we do? So we said, okay, we negotiated to work with all the physicians in the community. But the other physicians were admitting to a hospital outside the state because this was a borderline community between Georgia and South Carolina. And we were using Office of Research and Statistics in South Carolina to collect the data. And they didn't have access to Georgia data about outcomes. So we started and we decided, ooh, how can we do this? So we went directly to the physicians and started recruiting from physician practices rather than from the hospital. And we recruited folks with uncontrolled diabetes. That was good. And then the physician said, these patients who are uncontrolled, we don't want them assigned to usual care, because why would we refer them to you if you're not going to give them all the other things that you need? So here we are with 3 groups. What do you think we did? Anybody want to take a guess?
You offered to drop usual care.
Yeah, sure.
We dropped the usual care group because that was the feedback. And this really illustrates, and we got wonderful results. And now we're following those patients for 2 years to see if we can decrease hospital readmits and emergency room visits. And we have a collaborative agreement to get that data that we need. And we were able to reduce, based just on dropping A1C, we were able to reduce cardiovascular risk by 45%. But this illustrates the importance of doing small feasibility studies. This was not even a pilot study, it was a feasibility study to see, can we do this and how will it work? So again, I give you that example of the ideal CBPR and how we handled that. If we were on an NIH grant that was a very large grant, we would have probably had major issues unless we had labeled it feasibility study. But even with a large grant, you can see sometimes how important it is, because some of those issues were time related rather than community partner related. So systems may change, but if you're working with the community, we'll get an idea of what those changes are, and the community can have input.
So what outcomes did you measure?
We measured A1C, blood pressures over the period of 12 months. And then in addition to that, we measured quality of life and building social support and sustainability for diabetes management.
Pre-post.
Pre-post. But really the major outcome, and this is important to define your major outcome versus your secondary outcomes. And our major outcomes were two: A1C control and cost and hospital and ER utilization, because those were the expense drivers for most healthcare situations. What would you have measured, Heather? Other than insanity and crisis with the PIs.
The only thing I could think of in that case that I might have, if you could do it, would be medication adherence.
And so then, well, we used Marinsky's medication adherence scale. But my question is, how do you, what does the evidence say about measuring and how to measure medication adherence? Anybody? Guess what? The integrative reviews that look at medication adherence basically say there ain't no good way to do this. That is in my country language. But pill counts, pharmacy buying, pharmacy purchasing, there are all sorts of different ways to do it, but none of them are really good. And that's a challenge we're having in some other studies too with blood pressure control, because medication adherence is a major issue. So it may be easier with children than it is with adults. And I'm saying no. But they found that people, once you started counting the meds, that people were actually, they learned what you would do, and if they forgot, they would remove them from the bottles. So when you counted them, it was like, oh, they're perfect. Why isn't this working? And I was doing I'll give you these examples because I think this illustrates this real world issue. I was monitoring insulin adherence, and I was looking at what disappeared from the bottle, and why was this particular patient coming in with highs and lows. Her dietary recall was good. She said, I am taking my medication every day. Anybody got ideas? She said to the nurse one day, you know, I just don't know. My arm is getting lumpy. When she had been taught to inject her insulin She had been given the chart that showed the injection sites, but she had been taught with the nurse saying, and you go straight in. Guess where she was injecting? Right here. So that's another example of real world and some of the issues.
And I guess I asked my question because this issue of we don't want a control group, we don't want somebody to get nothing, is such a common roadblock when you're trying to bring research into the community. Because really, there's usually someone, the physicians or someone advocating, they know, like, look,
Right.
they're aware, it ain't working. Like, we need to do more. And like the last thing they want to do is sign up their community or the people that they're caring for same old, same old. However, as you alluded to, it's such a difficult position then when you're going back to your hospital or to your funder to say, I did pre-post. You know what I mean? Like, because that, then you feel like you're, kind of coming back with not the evidence you really want to, like, convince people, like, this is good. This will pay for itself. Just stuff
And what's interesting is talk to your statisticians who have some experience in alternative designs, because there are different ways to handle that. There is randomization, that is assigning your communities or assigning by groups where you can have enough pre and post communities to make it acceptable. There are other ways, there are about 3 or 4 different ways that we've identified for larger studies to avoid that nothing, that is usual care. And by the way, with PCORI, when you say usual care, you better define standardized usual care or they will throw it out. Because usual care in Heather's practice, usual care in another practice may be totally different. And we're finding that out with stroke discharge. Patients who have a stroke, their usual care in 3 hospitals that we're working with is totally different.
Well, it's one of the things that I was thinking about when you're talking about getting rid of that and the doctors wanting more. They were already providing usual care. So what were they then thinking was wrong with the care that they were providing? I mean, it's something to want more for your patients, then why aren't you providing it? I understand it's like a funding thing and not having the resources, but still, if you think you're providing good care, then that you should be okay with a control group that's getting good care. And so if you start with a patient is already getting what they're supposed to get, and what you're looking at is over and beyond that, it seems like you would be able to have a control group because people would feel that what they were doing was enough, in providing, what is best practice and what is good care. So
and the
confusing.
reality of today, and most of the people in the communities that I work with say, oh, my doctor's doing great care. And great care maybe with diabetes, a hemoglobin A1C measurement every year or 2, rather than what the guidelines say. So the key is, what is good care? And we're finding that it takes more than just that 5, 10, 15 minutes with the physician or the healthcare provider. So there's lots of benefits then to using community engagement as a process and getting communities to participate. And here you see many of those. But the other that I'd really like to point out is that sustainability. The challenges I've found with sustainability is, what is it that the community chooses to sustain? And is it really documented in good science. Because if somebody took our pilot study in Bamberg, where the sample size was 60 patients, not an adequate sample size to talk about outcomes. Certainly it shows a trend, but it's not an adequate sample size. But yet, 3 different agencies where we presented and said, this is a feasibility study, these are all the processes, have said, oh, we want to put a community health worker in our agency to do X. And I'm saying, ooh, we're not ready for that. Yes, it may work, but it really needs to be researched. So sustainability becomes a problem. The other is historically how communities are involved. And here you see the major involvement has been recruitment and retention and using the measurement instruments to collect the data. Very few have been involved in the proposal development, which you are involved in. So think about this and look at this from time to time and say, what am I involved in? How can I get more involved in this for my community? And what organizations can join us? What do they bring to the table? And how are we going to finance it? And again, how and what needs to be sustained as we move forward. And there are lots of complexities that you may or may not encounter depending on your agency that you're working with. And I don't know what the ACE awards in the different institutions here require, but because we're using federal monies for our program, there's all the federal-wide assurances for the community partners to get the money. Then there's training for regulatory and study requirements. We use city training. And you may say, well, we're not working with pregnant women. Why do we need to be trained in IRB to deal with this? Well, institutions tend to be relatively rigid with the training that they require. The other is the advantages for the community to learn about that. But those things sometimes are changing. Then there's the contracts and professional services agreements. And let me tell you, each organization or agency has different contract formats, professional services agreements, and there are different guidelines for those contracts. If they've worked together before and have certain levels of approvals, it's one thing. But the frustrating part is all these regulatory approvals. The other is budgets. What's required for managing federal monies? And there are lots of guidelines, because if Heather approves a budget and it goes to you, the federal government agency that controls that money can come in and audit. Now, how many do they do? We don't know. But again, manage money carefully.
So I just want to say on that, these funds are coming from the NIH. So they come from the NIH, flow through the CTR, and then to the institution of the academic investigator, and then out. So the good news about that is that it's really the maximum regulatory difficulty for everybody. It's really going to be a pain in your neck. So, sorry, it's, try to be funny, but it is true. So when Nicole or Jen Passarella ask you to get moving on something, some document or whatever, it really behooves you to do it. And you all have to be IRB trained through this city and get that all done, they won't release the funds for you to start your project until all those T's are crossed and I's are dotted. I's are dotted.
We can do some therapy session later, don't worry.
Yeah, if you can help me with that later. So anyway, I can't emphasize enough. I know it's a pain in the neck. I know it's not enjoyable. None of us signed up for that as part of our job. But the more you can be responsive as those things are asked for and move that along, the more you can be on target to start your projects on time. It is what it is.
And does it still have to go back to NIH for approval? So after you get everything done and you say, we're ready to start, we're going to start next week. It's got to come through Heather, go to NIH for approval, and then back to you, and that process can take a while. So just know that government regs and agency regs can be complicated. Then, when we're thinking about working with communities, what are our common data collection methods? And focus groups, informational interviews, key informant interviews, cognitive interviews, observations and interviews, like a walking interview. Focused ethnography is a new one that I'm using. So if you want to learn more about those, certainly we can provide references. And then with the more quantitative data, most of us are familiar with those. And so who best represents the community? Frequently, it's the persons with time, energy, and motivation that may not be the best representatives. So we want to look at diverse participants, what's their agenda, and what's missing. And here are two frameworks. This is the Community Systems Wheel, which we have adapted to our work in Africa. And it's one that we try to bring people from the table, because you don't think sometimes of the media or the recreational system is really fitting in some of the clinical research, but they can be very helpful. Another one is the 7 Ps. The policymakers and purchasers and product makers are important for certain studies. So look at who's important to your study, who might exert an influence. And then coalitions versus community advisory boards versus board of directors. Different definitions. Be clear on your naming. Be clear on the responsibilities if you're using a board or a coalition. And that way you can use terminology that's more commonly used in the academic world. Here's a PCORI example of stakeholders. And then think about what's in place for your research. What's the support of the academic infrastructure? And who's there to support you and develop professionally? Because your academic researchers are evaluated for their promotion and tenure, that is, moving from instructor to professor, based on certain guidelines. And so they have to generally publish peer-reviewed articles. And sometimes with some of the communities that I work with, that's a problem. Then what's in place in the community? What's the infrastructure there? Take a look at your infrastructure. Look at what's there. Then you're going to spend some time saying, are we ready for partnerships? And the goal of this toolkit is really to help you explore your partnerships pre-research, establishing guidelines, establishing communication, etc. And is it a good fit? Because sometimes our partners with academic and community are not the best fit. And how are we going to operate? One of us may say, well, the only time I can do this research is at night after I leave work. And another may say, oh, I have 3 kids and I can't do anything at night. So these are the issues that you need to think about. And that manual was produced based on evidence and the model you see here. Then the Memorandum of Understanding. When I first started in community-based participatory research, the Memorandum of Understanding and the contract said the community partner X will do 1, 2, 3. Guess what was missing? The academic partner and the academic institution will do 1, 2, 3. That was no place in the contract. If you're signing a contract and that's the case, sit down and say, I need a more balanced contract. I want to know what you do. You want to know what I do. Let's get it on paper. It may not fit with the university contracts, but it's a way to do it. Then your decisions and communication plans, and how you will communicate with partners. And look at how you view. This is just an example that I always show where we talk about the traditional medical model approach to diabetes and the community that I work with and their approach to diabetes. And you see what we see through the eyes of different folks. And it becomes a major issue when you're setting up and doing research projects. So, successful community engaged research and care involves a commitment to long-term investment, openness to organizational change and culture, a willingness to share power, and development of trust and respect. So, successful research proposals generally involve all of these items. Specific aims are really, what are we going to do? Why is it significant, and why do we really need to do this? And what's the gap? And that's in the significance. Then exactly how we will do this, and you'll hear us as we talk about your grants, about some of the strengths and weaknesses, about how are you going to do this that may or may not be spelled out. And investigators, who are they? How are you going to evaluate? Will your community evaluate? What's your best guess of a timeline? Your budget, who's supporting it, and then of course the human subjects become important. And I know at Harvard and Yale, they actually have to consent members of their community advisory board because they're keeping research notes and minutes and analyzing that. So the community advisory board are research subjects. We don't have to do that at MUSC. And so ask yourself, are the right people at the table? Does the process and structure allow voices to be heard? How are people involved? And what kind of learning has occurred with both of you working together? And then here is just one example of an evaluation model that are an evaluation guideline that you may find. There are lots of academic books available on evaluation, but this is nice and concise. And they address partnerships, leveraging products and dissemination, education and training, as well as capacity building, and logic models. So, finally, community-based participatory research. Are we there yet? Yes, we are. But who's at the table? And if we're not there, then do we have the real world and the academic institution together to really work that out? So just remember in closing that good intentions do not equal good results. And we do the best we can. But think about the goal. Work toward the goal. When the conflicts arise, keep your goal in mind. And I will stop there, Heather.
Thank you.
Questions for Carolyn? Comments? She's a hard job to cover all of that. But you know, you're not going to learn it in a moment anyway. You're going to learn it throughout the project, throughout the curriculum, throughout your career. So, all right. Well, why don't we take just 5 minutes and we'll get restarted here at 10 o'clock. Okay. Tell me your name again. You said it and then it flew out of my brain.
Kathy Rhodes.
Kathy Rhodes. Nice to meet you, Kathy.
Me too. Thank you.
Sorry you're struggling with traffic. I know that's stressful.
Oh, 95
sometimes.
is awful, and so I have to figure out a different route.
The bathrooms, if anyone's looking, which is what we call a mock review. And the idea here is that we sort of take the lid off of a box where you would normally not get to look inside. So most reviews happen behind closed doors. There's, a review, a discussion, scoring, and then people decide, sort of like, Caesar, thumbs up, thumbs down, whether or not you're going to get funded. You get and should have gotten comments back on your proposals, but you don't really necessarily know what all they are saying. So we're going to take 15 minutes per proposal. I've asked Dr. Sharif and Dr. Peterson to each review one of the proposals. In order to keep it the way it would be in real life, I'm not going to let you interrupt them with questions. So even if you don't like it, no? Did I? Because you're the mentor.
Yeah.
Carolyn's doing it. I'm sorry.
I feel like we can say anything and then leave.
And I'm sorry.
Maybe can we ask questions at the end?
Yes.
Great.
Does that sound okay?
Because at the end of each individual review.
That's fine.
Okay. So we're going to do Mike first and then Carolyn? Is that?
Yeah,
Right.
Mike's will be first. Let's see, Mike, which one are
I'm
you?
doing.
You're doing Cindy's, and I'm doing Laura's.
Right. And then the third team is actually developing their proposal over a year, so there's not a third proposal to be reviewed. Okay. So with that being said, I'm going to hand it over.
Okay. All right. Well, thank you for the opportunity to read these proposals. In fact, we read a lot of different proposals. It's really nice. It's nice to only have to comment on one, right? So, because I think I read most of them. A lot of them I couldn't, but many of them I did. Just to give you a little bit of background about me, because it actually sets the stage. I want to set the stage for the review. My background is in behavioral medicine or behavioral psychology and health promotion or community health promotion. So that's my background. I studied at the University of Kentucky, so I'm an SEC person, like everyone else. At least these proposals are. My background, I've worked anywhere from the prison population, the Federal Correctional Institutes, to inner cities, to among the HIV population, to working with people across many different dimensions and places. I've also working right now with the health coaching program, developing that. We're actually the first clinical program in the country that we've actually started. That's actually a full clinic, and that we're actually getting quite a number of clients at the moment. And we'll just put it that way. They're not patients because we can't have third-party reimbursement yet, so that's part of it. The reason I say that is because this proposal is on severely brain damaged children, and I have no background in that area. And that's why I put that in there, because one of the things is that, and when you have a review, sometimes you're not familiar with the topic, and so therefore the onus is on the writer to make sure that I understand what you're doing, right? And so I'm there. And the other thing I want to put into practice is that first thing I do when I look at a review is I take into account the nature, purpose, and scope of the grant RFA. So I'm looking at what's the purpose of this, what's the size of the budget, all those types of things are the criteria which I am actually now evaluating the proposal. And then I look at it broadly speaking as whether it's meaningful, measurable, or doable, right? And those things. Those are kind of the three guided principles that I utilize when I look at this. Now, as I went through this, the first thing is that you look at this page and I see that there's an abstract that gives me the project focus and it tells me the research summary. And this was actually very clearly written. And the first sentence was actually a very good sentence because the first sentence to me is everything. It draws me in or it turns me off. And the first sentence, even though it's not my area, it says as the number of children with severe brain damage and complex disability increases. That's a great sentence right there because it's increasing, it's a problem. Well, now you've defined it, and I'm an uneducated person on this topic, and so you are actually garnering my attention right from the beginning. So validation of appropriate outcome tools such as the PASMA become more imperative. And these key words, I like the words they use. I'm a word person, and so the words there show some urgency, it shows some severity and some significance right from the get-go. You're not wishy-washy, and the sentence is actually very clear and distinct, and it gets my attention. It's written very nicely, right, from that standpoint. You also go on in this to clearly state that there's ties between the academic and community partners. And so within the first paragraph, you already have satisfied, you've got my interest, and also you've said that you're meeting the demands and requirements of this particular contract, right, or this grant proposal. So as we go through, right, the rest of the pages are kind of there. Again, you reiterate. The project summary, again, is just repeated, which is fine. That's here. Let me just pull ahead here. All right, the significance of the problem. Again, this is what is the ratio. What I have in here. Okay. Secondary, I have just questions, and most of these are minor questions as they go through, and it's mostly because as a reviewer, I'm inquisitive now. I'm thinking in terms of I'm inquisitive. I'm looking at this and going, you talk about the growing population of those with severe brain damage, and the one thing you didn't provide was the rate of growth. Is it? There's lots of growth, but what is the rate of growth? And that was my first question. Well, how fast? Is the rate of growth? Is it something I should be really concerned about, or something that's just gradual over time? And that's just minor. But it's not anything significant. It's just what I think as I go through this. The second paragraph, without appropriate tools to identify and measure the subtle abilities and behaviors of children with severe brain damage. That, again, is saying that it's speaking to the onus, the significance of the problem. It's stated in a nice way. You also state clearly what is the order. In order to do this, we have the purposes of this proposal are, and they're very clear purposes. I understood them well. And you focus very clearly on all you want to accomplish on this is to validate an instrument. Okay, that's it. And I look at that with a $20,000 proposal. I say that's doable, right? You can do that, right? If this was a $100,000 proposal, I say what else are you going to do, right? If it was a $3,000 proposal, I say okay, why are you even bothering, right? So it's just generally what I'm looking at. So it keeps it within the scope of what can be funded. And that's fine. There's a good explanation of why this study is needed in terms of innovation. That's there. That also makes sense. The engagement plan, you gave the good development and background of what you've been doing and how you've been engaged in different ways. You talked about how your relationship was formed, right? And that would give me some background as a reviewer to say, okay, this isn't a fly-by-night. This is something that's been developed over time. In other words, you put me at ease in terms of looking at this and saying, okay, this is somebody that's actually working together. So I see involvement from the get-go of the community partner with the academic partner. And I think as Carolyn mentioned in her presentation, one of the things was that's very important. And I was looking for that too, whether this is just a fly-by-night or how committed is the community of partners. Usually how committed the community partner is. The academic partner is usually looking for money to do a study, all right? Not to be facetious, but that's typically what we have to do. That's our jobs, and so that's why I look for that kind of relationship. All right, the other thing that I like is it's a style, and I don't know if you wrote this way, but it's my style, and so I like it. So that was kind of what it was that you do bullet points, and you here's step 1, step 2, step 3, and from a proposal that tends to be in a 10-point font and single space, it helps to highlight things, and that's just a formatting issue. that relates to what do you want me to pay attention to? I'm a marketing person also. I do a lot in social marketing, and so I look at things, how do you make the information presentable so that the reader or whoever the audience is can get the meaning clearly. That made sense to me, right? That went well. And then you also talked about the potential for future work. Now, you introduced that here at the beginning, and you talked about other things that you will be able to do in the future, which is good, because it shows me that this isn't a flash-in-the-pan proposal. It's something that's an investment, and that's how, actually, from the nature of us, when we look at the CTR, every one of these proposals is an investment. It is not a one-and-done. In fact, some people did not get funded because it was a one-and-done. Right, and that's a nice study, but you're not going anywhere with this. And so we're looking at what's the next step. Can you get potential future funding? Because that's the purpose of the RFA. All right, you talk about the PASMA needing more, must be validated for construct and concurrent validity. Having done that myself, this made sense. I've done my own psychometric tools and had to validate them and do that as well. So I understood what you were doing. The one thing that I had as I went through here, it's a picky point and related to more the science in this. This is based on your previous comments, where there is no gold standard for pediatrics to serve as your concurrent validity option. And it says, but what needed to be said is this is the best available, right? And that kind of thing. It was implied that we're using this because there's none available. But the idea is just to say, well, it's the best that we can do, and that would help in terms of this. It's a very minor point, but it's generally a point that I would look at. Your approach to this is very simple. It's very logical, and it follows appropriate methodologies related to the validation of an instrument. And then you talk about your aims within this, which is aim 1, aim 2, aim 3, which for me was well stated as I went through here. When you went into your research design and methods, as I went through that, immediately when you say only 15, all of a sudden that's a small number. And so as I go through this as a reviewer, I'm asking questions, and actually I write in the column what about this, what about this, and then I'll go down and say, oh, it's answered. Okay, and so the proposal was actually nice because as I was asking my questions, you were answering them in the next paragraph. Right, or further down, so I had an idea. So that told me that you understood that these are the issues, but you had to address them, because a reviewer is probably going to look for the same issues in a study design. Like, why is this so small? Oh, and why 21? Why is that a child? Right, that was my first question. Like, 21 to me isn't a child, and then you answered in the next paragraph, a 21-year-old, because of the brain damage, is considered for this population to be a child. And I said, oh, okay, that makes sense, right? And then you had, I think, a nice reference in there somewhere. All right, to do that. As we went through, it made sense. Your measurement plan 5 times over 10 days. So I got an idea that it's a multiple measures and it's repeated measures design as you're looking through this. So that was fine. And looked at different things. I had to go back and I would flip to your appendix, because when you're looking at this, but you also had in the appendix, which is the description of what you do, and that's helpful for me because I don't know your field, and I'm going, well, what are these measures, right? And what do you do? And there was logic to it, and it made sense to me for someone on the outside who's not familiar with the subject matter. All right. It would have been nice. One thing that you did do as you went through the research design and methods, you actually finished your 4th page by saying that actually talked about future objectives, and it helped me to see where you're going with this, which is a good thing. All right, the pediatric Glasgow Coma scale. There was you set this up in a nice way. There was comparison issues because it's dealing with adults versus children, but then you went ahead and justified it, right? Which was important. So in other words, what you were doing was saying, we acknowledge that there's a problem, there's nothing out there, and we have to use the Glasgow Coma scale because that's the best we have. Although it's a pediatric, it's different, right? And you were justifying it as to why, and that was helpful. The First Beat Bodyguard 2, I thought this was interesting, right? As an instrument tool, it was another alternative validation tool. I've never heard of it, but as I went through this, I said, oh, this makes sense because I would assume that people who have brain damage, the heart still functions well, and it's an indication of reaction. Is that correct? Right? That's what you're doing, right? I can ask you a question, right? But we don't do that. We'll go on. Anyways,
Yeah, no, can you hear me now?
yes, that's what you're doing, right?
Okay, no,
Usually
that
the heart
is,
rate
but they don't
reacts.
they usually have, we want to see, it's what I'm doing, but you,
She's breaking
we
up.
want to see a lot of variety. We usually see less variety, you know.
Okay. So that's what, so it was interesting to me. Now, the procedures were nicely done, and it's nice to number them, and it keeps it as a logical way to look at, especially for someone not familiar with this. I know step 1, step 2. I could actually repeat your study, right? I could actually go through, and I'm not in your field, I could do your study, right? I mean, I interpret it properly, but I would be able to do it, and that's what I was saying is very clear. The only recommendation I would have for this is that your IRB, you give this, but you don't highlight your IRB and how you protect your human subjects. That would be the only thing that I would say as a recommendation. I would have done what you did with 1 to 18 or whatever, 1 to 20 in terms of 21 in terms of your steps. But I would also have inserted a protection of human subjects to clearly articulate to me that you are doing and you are going to protect the human subjects and their rights, right, in the study. It was implied in here, and you have it as part of your procedure, but it would have been nice to just have a little paragraph that would have explained it again, even repeating it, because I don't think there was a page limit on this. Was there a page limit on this?
Yeah.
There was? All right. Well, you'd have to make that judgment call based on page limit, but it would have been nice to see that. All right. The other thing I had here, which this is from the CTR perspective. The purpose of this is to provide funding to create pilot data or to do something which will then lead to future funding. And then I would read something like, the COI's consultants and mentors may use the data to this project to support a grant submission. The term may was a red flag to me, right? It's minor, but it means, well, what do you mean? You're not going to do anything else? Is this it? So that may, and this is really picky, but this is the point that we're getting to, because we're responsible for identifying projects that have legs. And then if we have someone write and say, well, we may do it, well, that leaves doubt. Now you've introduced doubt. Its purpose, the intent of this is to, you could use other terms that would have been helpful, right, in terms of language. Intent doesn't mean commitment, but it's a better word than may, right? And then in terms of my views. The selection criteria statistical analysis was fine. It made sense. And also you gave me the ranges of acceptability, because that was one of the questions I had. Well, how do you know? What are you going to do for this? And that was helpful. You also, in AIM 3, you provided limitations to the study, which I thought was very important. That was there so to acknowledge the troubles that were there. All right. Again, you introduced again, we may do this in terms of following up, and that was cited 3 times, right? They used the term may. We may do this in the future, we may not. So that was kind of the idea that I would was a bit there. The only other thing that I had that was next steps was fine. You put the next steps in here, and then you actually were much more definitive that this is what we're going to do. But you had already introduced doubt to me, because I'm reading every single word as I'm going through here. And I'm going, what is, you put the word may, and then at the end you say we will. Well, then now, okay, are you going to or you're not? And so I give you the benefit of the doubt on this. But again, it was a nice little summary. You provide the appendix, that was fine. The budget made sense. The budget actually reflected that the community and partners were going to be committed to this. That's what this told me, right? And that the academic partner was doing in kind, which is typical on these type of projects. So I'm like, fine. That means you've already committed your time. So the academic partner committed their time. The community partner is now committing to this as well, because there's resources that are going to the community partner, right? So I look at that and I go, okay, that's good. Right?
Hey, I just saw him back in, and I can hear it. It's just.
I can't repeat it, sorry. All right, other than that, the budget made sense. It was appropriate for what was going on. A lot of travel involved, it seems, but it was what it was warranted and justified. Your bio sketches proved that you had the ability and the means to do the project, right? That was the other thing that we look at. Even though you write them and you wonder whether we actually do read them, and we say whether or not you have the ability to do this, or are you qualified to do it, and that was clearly put in there, so I didn't have any problems with that. And so as we went through those, and then I don't know why you included something else. Oh, yeah, the other thing was that had to be addressed in here was clearly this is a follow-up to another grant proposal that you got from the Physical Therapy Association. You did clarify this in your grant, but essentially I asked the question is, are you double dipping? Right? And that was the question, because you're saying, well, we're doing this, and you already wrote a grant proposal that said you were going to validate this instrument, and now you're writing another proposal that says you're going to validate this instrument. And I'm like, well, okay, so what are you doing here? But you explained it in the proposal. You stated that we couldn't, the sample size, you're trying to enhance the sample size, you're trying to do it with a different, not necessarily a different population, but a different site, which means that you're looking for, in essence for me, it's methodology. It's can you reproduce the validations of you would get in one group with another group, and that was fine. So you actually did explain that to me, and I was happy, right? But it was, overall though, the proposal was an excellent proposal. I don't have a lot of things. My points are very, very picky. The proposal was very well written. It was clearly met the designs and needs of the grant, right, the RFA. And so from that point, I mean, other ones I could rip apart a lot easier. This one was really hard to rip apart. And so what I was trying to do is look at things that would be pointers from this. But overall, it was an excellent proposal. And I think it scored very well. So overall, by all the reviewers that's there. What my hope would be is that this study leads to something bigger. That's what my hope is, right? So the next step would be to make sure that it does that. Now, it'll be different because it'll be a different grant proposal, and so therefore, you'll have to write to those parameters of that grant, which I would assume there would be more involved with it. Okay? That's it. Sorry if I took too long.
So you're good.
Okay.
All right.
Questions or comments, or you're fine?
Any quick questions before we move on to the next?
Yeah,
I think that's it. Okay, thumbs up. We're good. All right. Thank you very much.
Thank you.
Thank you.
And I guess, Mike, one question that I would make or ask relates to next steps, because if this instrument does not prove or the validity, reliability, factor analysis, etc., really don't work out, what guidance would you give this group related to next steps?
One of the things is that you when I first review it, my assumption is that they're going to find something, and it could be that it's invalid. But what they could do is identify what is it that made it invalid, and identify and analyze what it is they can improve the instrument and make it better. And the key is that's the focus when you're looking at any of these things. Now, some of the proof has already been done. You already did some alpha analysis and looking at those to see what's the best criterion to include in that. So that's already been done, and you already had that listed, right? That's there. So now you're looking for concurrent validity, which is it based on another standard? Does it reflect the same standard? And that's really where you're at this point. So from the criterion validity, you've already done that. It was the concurrent validity that was there. And my assumption would be, and this is assumptions on my part, would be that if you weren't able to find concurrent validity with this particular, the pediatric coma.
The Glasgow coma.
Yeah, Glasgow coma thing, then perhaps it isn't the gold standard that you would need to do. So you would have to think what would be the next step for that.
Right. To find a different.
Right. Yeah. How else could you create concurrent validity? Reliability is another issue that was there that you could have addressed. I mean, you could have looked at reliability, and you did have inter-tester reliabilities, that was listed in there. But reliability over time, that would have been another thing you potentially could have addressed. Right.
And then my other question relates to the community partners in understanding this whole language of validity and reliability and instrument development. What has been your history? Because that was the other question that wasn't really clear as I think about that. So it would have been really helpful to have a documented, oh, this is why we're really interested in this.
Yeah. And I think even just to point for your question, a lot of the assessments that we do on these children, because there isn't anything that we can really turn to and say, this is how we measure this, are really more informal observations. And we write quite long narratives based on what we see from our kids. And I don't think that would change, because I think that that's really essential to sort of what we do. But to have something that sort of backs it up and bolsters it and kind of gives us something that we can point to as a way to also measure decline, or because even though CP is supposedly a static condition, it's not necessarily. And our children change as they grow in age, and have different medical conditions that come aboard, and certainly with movement and those kinds of things, it's a struggle. So I think that to have something that we can turn to that gives us an idea, because a lot of what we find among all the different parts of our at our school is that different therapists use different measures, and I think it would be really important to kind of pull together to have something that we can look at across the board.
Standardized.
Yes,
Okay,
absolutely.
very good. That to me is helpful. To see what your passion is in engaging in this. And I think if that were documented, it would have made it a little bit stronger. Not that it wasn't strong, but as a mentor, that was okay. Why?
Yeah. No, I get that for sure. Yeah.
Okay.
Thank you.
Thanks, Mike.
Okay. Thank you very much.
Yeah, that was great.
Yeah, switch hot seats.
Okay, so I will just describe the project very briefly and then offer a few comments, and then what I'd like to do is give you an opportunity to ask questions. So the research summary, and so we all know, I'll just read it. The research project aims to build capacity for social skill interventions for autism spectrum disorder, abbreviated ASD, so I'll probably use ASD, for adolescents and families in community treatment settings across the state by implementing the Program for Education and Enrichment of Relational Skills, titled PEERS, a social skills group program developed at UCLA. And in Delaware, the Child Guidance and Family Services will use this. The primary goal will be to expand education and implementation of PEERS at DIGS, including underserved regions downstate, and explore outcomes related to social skill development or social skills symptoms, parenting stress, and family quality of life. So as I looked at it, it really was an exciting proposal. And I was like, oh, just what a community needs. And I wish I could bring it to South Carolina, but I don't do kids. So you have to understand that. You have to understand where I'm coming from when I say I don't do kids.
Well, if you put it out there, I am very passionate about autism. I might find a way to come to South Carolina and put it out there. So don't tease me with that one.
Yes. Yes, and so laughingly, I say I don't do kids and I don't birth babies. So otherwise, I will do adults and anything from 21 to old age. But this really was exciting, and I looked at it really as a program implementation and evaluation grant. And that's what I think this was or is, and I think that in your significance, you clearly outlined why it was important and why you need to build capacity and how you will focus on your evaluation. So the innovation was really, I thought, well stated in that you want to show improvements in social skills in adolescents following your intervention, but that there's been no studies on the intervention of caregivers, and so you will look at parent stress and quality of life at baseline, that is pre-post. And there's no research on the impact of peers education on staff implementing peers. So to me, those were exciting innovations, and particularly my passion is underserved areas. So when I saw that, I'm like, oh, yay, right, just a perfect program implementation and evaluation, and probably a challenge. And this is a 2-day education program, and then it will be evaluated again following each 14-week group intervention. What I wasn't sure of is when that statement was made, I'm like, wait, help me understand. How is this delivered? And so it made me say, oops, I need to go back to the literature and see how this has been delivered in clinical care, and then how you're moving it to community. So I think that could have been more strongly explained. You said you were doing it, but I just wanted to see some of that. And I certainly applaud you. The engagement plan, I thought, was clear, and then when I got to specific aims, I'm like, okay, here are 2 specific aims of building capacity for ASD interventions by providing formal education to clinicians in peers, and then to assess the caregiver and adolescent outcomes following participation in peers. And I'm saying, okay, those are the 2 aims because that's where you're addressing the void. But how does that link back to the adolescents who will participate in this and maybe say, I'm not interested? And I think that is kind of what was confusing for me. Then your methods, I really wanted to see these methods outlined by aims, and they were kind of blended together. And I think because when I go through and look at methods, I really like to see that all the way from this is the way we're going to evaluate our peers who are delivering the intervention, and this is the way we're going to evaluate the family. And then how does that tie back to the intended outcome of the program, which may or may not be effective in some of these areas. The other question I had related to really the cognitive pre-testing of this program. And I know this grant does not give you enough money to do all of that, but is there a way that you could at least have a discussion group with the folks that you're going to train to deliver the program to get their input? So more qualitative sorts of things. Because as I looked at your instruments, I had very little information about your instruments. So I really, and I'm not a PEDS person, so I didn't know these instruments. And you used abbreviations, and I'm like, okay, what is this? So always spell out the name of your instruments and then abbreviate. And so somewhat of an explanation of the instruments and why they were chosen would have been helpful if it had just been a sentence or two. And so I thought that would have been good. And then what's included in those instruments, kind of just a brief synopsis of those. Usually what I like to see with instruments, because that's the power of what you're doing. You're doing an evaluation of the peers and of the family. And so I like to see a table that lists the instruments, that briefly describes what they measure, and also the validity and reliability of those instruments, because if you don't have a valid and reliable instrument, then your whole program evaluation is meaningless. And I'm assuming with UCLA that they probably have the validity and reliability, and that maybe it's been tested in underserved populations, but that was something I'm like, ooh, is that the case? So I think that would have helped me. And then I thought you talked about pre-education, post-education, and baseline, and pre-peers intervention and post-intervention. And then when I got to the statistical plan, I was like, okay, I really wanted a step-by-step. And I'm not sure that all of this could fit in the space. But if I were doing it critically, I would want a step-by-step. Where is this administered? To whom? And how many people do you assume that you may be administering this to? Then you did talk about the data would be entered into a secure database, but when you're administering the instrument, is it going to be a paper and pencil instrument? How are the data being transported, or are you going to enter it with a tablet? Those sorts of things. All of that was kind of foggy for me from reading the proposal. So I tend to be, let me just tell you, I teach advanced measurement to our PhD students, and it's all about looking at instruments, what they measure, and what's the validity, and how are you going to do that. So I'm coming from a tainted background of focusing in on instruments and measurement. So that I did not see. I think the impact, I think it will make a significant contribution. I just want you to think carefully about outlining the process, because when it comes time for publication, I think that's going to be the issue then. Just as Mike mentioned with the previous grant review, I really wanted to know clearly, other than implementing this program, what would be the additional research projects, ideas for that. And I wanted to know where might be possible sources of potential funding. Because I think that when we start a research project or a research career, the academic person in that career needs to have basically probably a 5-year plan, at least a 3-year plan, probably a 5-year plan. And where do each of you want to be in those 3, 5, 10 years down the road with this? But I think it is something that will be very meaningful to the folks in Delaware, specifically the parents who struggle with this issue. And so I think you have a strong mentor who can support you in this. And overall, I found it exciting. Budget-wise, by the way, I'm sorry, I didn't get the budget. Because I'm a mentor for the other group, I didn't do the reviews like Mike did. So I have basically the research plan. Other comments or questions?
I mean, I think I agree with the reviews from the standpoint of, I'm much more excited to implement the project than to go through and think through the processes. So I agree with you, because that is not what my love and my passion is. And I think that it's a work in progress as well, because I think that with the new partnership and working with Delaware Guidance, we don't know all of the processes. And so trying to pull together a proposal and a grant on my 100% clinical time, it's just those details I did not think through. And I don't think Kathy and I thought through, because we knew that we're going to have to and we're going to have to do it later on the back end. But it's good to hear, because I think those are things we're going to have to think through and figure out as we go. But we're not things that were the priority in giving a proposal.
Oh, and I clearly understand, and from my knowledge of the Excel grant, it truly meets so many of the criteria for improving health in Delaware and beyond. So I just,
but I need to do those things eventually. Yes. Yes.
And that's what you'll learn.
Yes. Right? And that's what's been great with working with Dr. Sharif too, is she's been, yeah, it's great that you have these ideas, but you have to actually do it in a mindful way. And so I'm learning how to do that. So I think that the feedback is very helpful. Like, yeah, that would have been great to know those things, and to be able to strengthen proposals in the future.
Yeah, and I think the other is, I know as a 100% funded clinician that you're probably struggling. And as a researcher, what I know is that clinicians rarely have release time. And so laying that groundwork, and I don't know how far you are post MD, but laying that groundwork, particularly if Excel goes in for a CTSA, hopefully they will go in for a KL2 award, which is for folks who really want to improve their research careers. So
just also as another comment, so I don't know, people probably don't know that this is Laura's third grant award in the past month or something.
Oh, yeah.
Congratulations.
So she has a bunch of, and they are program grants, so.
They're
And program grants are hard grants because now you have to do stuff, right?
Right.
So,
Yeah.
it's a lot of stuff. It's not, let me plan my next research study, which that would have been hard too. But 3 program grants in a month is pretty crazy. But I think, again, as Carolyn is saying, and as Mike said before, that whole, having what you're going to do spelled out, like a recipe, like a cookbook, like I understand this now, I can do it. You want to get to that point, and as Carolyn just said, do that now because it's going to make the manuscript easier to write. That methods piece of the manuscript can be the easiest piece to write if you have it done from the beginning. So
But write it,
write it now, so that you have it, because if you don't write it now and try to write it backwards, it'll be wrong. So you want to plan it forward correctly, 100%. You want to have, how much flour you're going to add, how much sugar, how much water exactly. Otherwise, if the cake flops, then you really can't go back and fix it retrospectively. So try to plan it out exactly. And you're already doing that, but that's the thing.
And there are things too that I think that I would have done differently, because as we've talked about, it really is 2 projects, looking at the clinicians and looking at the caregivers. And it would have been really nice in the proposal to have here's one project and here's another project, and match the aims and spelled it out. And I think I didn't really even realize that until after all of this had come. So this is why it's good to get the feedback, because then you can think, okay, in the future, how do you spell this out in the right way and make it really like a recipe.
And one of the things that I frequently do with my PhD students is I give them examples of good grants. So I'm sure folks will probably share those with you. Certainly I will share. I just don't get these grants, but that's something to think about. First is using a really well-developed research grant that kind of looks at your process, and then not that you're going to copy it, but how are you going to use it as a model?
That's been helpful for the IRB. But Dr. Street's been really helpful in sharing, because as I've gone through the IRB, I've had to think through some of these things even more than we did for the proposal. So some of it's been ironed out a little bit more than the proposal was, but it's been helpful to look at other examples.
For sure, the document you prepare for the IRB is different. You know what I mean? And you're like, oh, those are details that I didn't include here because it's a different audience.
And the frustration part with this IRB process is each institution is just a little bit different. And so we've learned that NIH is really looking particularly for multi-site across multi-universities, looking at one IRB. Right now, our community engaged scholars, if they are from a different university, they have to go through that IRB, they have to go through our IRB, and then if they have to change one, they can't go into one without the other. And I don't think you guys have that problem, or do you?
Well, this project is simply gone through the Nemours IRB because it's not a really multi-academic institution. So it's all over Nemours.
It sounds like a really fascinating project, and I just had a question. For the measurement of the caregiver stress level, are you creating a tool? Is that what part of it is, or are you just, how are you measuring that? Because I would love to know. Because I think that, I've seen some studies that measure specifically, I was at AACPDM a few years back, and there was a study that looked at measurement of caregiver stress for parents who had children and young adults who had motor dysfunction. And it looked more at the physical limitations that some of these families develop as their children age, and that was a huge issue. But I was just wondering,
Yeah. So the parents, it's called the Parenting Stress Index, PSI version 4. It's a short form, so it's 1 page long, and it's a lot more about parent stress, their perceived stress level versus does this illness or physical limitation, or does it doesn't ask those questions. It's more about in general how the parent is responding. some of our psychologists that study like some of the more severe medical kids, like that have cardiac issues. It doesn't seem to be a very sensitive measure because those parents will say everything's great the whole way through. We haven't qualitatively, again, in autism, haven't found that to be the case. Like the measure itself is validated, but it hasn't necessarily been validated for cardiac, autism, diabetes, cancer. It's more general.
It's really about parenting, right?
It's about
It's
parenting,
like the
yes.
parent and the child relationship as opposed to what you're.
Well, one of the things that we found too is as our population ages, our parents' perception of status quo and everything being fine changes for depending on how many years they've been, having a child with these kinds of issues. So, yeah, it would be interesting to see if the older population, the parents have less stress because they've been through it versus the parents who are newly being
Sounds like
diagnosed.
another project in the
Yeah.
And then the demographic factors that enter into that. A good demographic description of the parents, and I think would be good if there's a way that the folks would be willing to do a qualitative description. Stick it in a file, and when your time, or give it to her with somebody who does some qualitative look at the data might be another way.
I think I just got back in. It's just, there's 60 kids here, and it's more of a traditional kind of school that doesn't have quite the technology.
There's something called the Caregiver Burden Index that is used in Alzheimer's and dementia. So it might be
To adapt
interesting
something
take
like
look
that to a
and see.
pediatric population.
I mean, I remember it, and if you email, if I tell you I'll give it to
I'd
you,
love to see it.
I'll forget. But if you email me,
Absolutely.
I don't delete emails until I respond to them, which is why I have a million. But
I'm sure that if we look at at Ann Kazak's,
Which is
National
really
Child Traumatic Stress Network, and which really is talking about medical stress.
Mm-hmm.
And I'm sure that we can also find things in there.
It's just a fascinating area.
Yeah, it
that
really
I'm
is.
Very
But you're
interested
putting a lot
in.
of ideas in my head, so I'm sure you're working with Family Voices.
No, I'm not.
No, so Family Voices has been really a great partner for us in pediatrics and also with our practice-based research network. And we've been talking a lot about studies involving children with special healthcare needs and what kind of screens we might be needing to do in order to help address issues that parents are having. So maybe there's a research project here really that we
Well, because
Is there a difference, because you guys are in Philadelphia and Family Voices is in Delaware? Does that matter?
But Family Voices is everywhere.
Oh,
So
okay.
it's a national program. They have a site in every state.
coming from a background of feeding, which is
Yes.
like probably one of the most stressful things for some of our families,
Mhm.
it's
Absolutely.
across multiple populations, including the ASD population. It can be
And we looked
of
at,
interest.
with our American Heart Association Health Disparities Stroke Recovery Grant, we looked at, one of my colleagues has looked at caregiver instruments that we can use, because that's another big issue. So I'll gladly, Heather, I can share those once I get back to South Carolina and see what those instruments are. And we're actually working on a paper to look at some of those.
So next week, we will be at the Ammon Center down in Newark. Okay, so at Christiana Hospital. That also has remote, for those of you that are going to, attend remotely. There are 2 didactics webinars to watch on the CTR website. City training, if you haven't done it, don't tell me, just tell me that you did. If you need help anymore, Dr. Sharif would be glad to point you to the people who will help you get set up. I know sometimes I know it's sometimes hard, to get the community partner the right identification to get into the website to do blah blah blah. And I know it's really really boring and long. But the good thing is city training is becoming more and more uniform,
Yeah.
so it would go with you. And once you do it, the renewal is not that bad.
That's great.
And next week we'll be doing the live IRB sessions with the leads. So as you think about, as you're watching the webinars or updating your proposal, and you think about this is an ideal time to ask them specific questions about your proposals, so that you can kind of put in there what you want and hopefully not have any bounce back and forth in your pathway to IRB approval. And then we'll do the first part of the Are You Ready toolkit, so it'll be fun and interactive at the end. And I'm excited. Thank you all for coming. Thank you. So, and Nicole's gonna try, we'll try when you guys aren't here, because it's sort of like, there'll be like, work in class, split up into groups. It may be that we just have to default to like phone, but we may be able to set up some WebEx and things like that. We'll see.
Okay.
And so Cindy and I are working on WebEx.
Okay.
And so just expect an email from one of us that says, and this is what you do, just get on your computer. And we've had pretty good experiences with connecting. So
Great.
Terrific.
All right. Thank you all for coming.
Thank you.
And we're off. Are you gonna be able to make next week?
Yes, actually, because I'm spending
Clear
a
my
day
cache.
in Newark.
Sounds like it's
After that.
gonna be
So that
more
would
than
have
that.
to-
I wasn't sure where things were going.
Yeah, no, there's one week that I know I'll have to
And we don't have Monday.
phone in or relax.
This was really nice. It's okay, it was lovely. Goat meal was awesome.